And now at this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Well, thank you very much, and welcome to everyone. This is Fraser Ratchford from Canada Health Infoway. This is, in fact, our fourth webinar in this challenge series, and so all to do with the Data Impact Challenge. On this particular webinar, we're focusing on the rate of screening blood tests and the rate of annual physical exams for adults. You've all dialed in, so get a check mark there, but we encourage you to use social media during this webinar. Our handle is @Infoway, and if you use the hashtag #DataChallenge, that would be great. This particular webinar is being recorded, and all of our webinars are put up on our microsite so that you're able to listen to them afterwards if you were not able to participate, or if you want to go back and hear something in particular. We are, as Carmen said, using the Q&A feature, so if you do wish to ask a question, look in the upper right-hand box of your screen, and you'll see the Q&A button up there, and then type into all panelists. So during the next hour, what we're going to do is I'm going to give you a bit of a background to our challenges, and then my colleague Simon Hagens, along with Kira Pendrith, are going to give you a bit of a summary of findings, and then we're going to have some team presentations from two of the teams that participated in the Data Impact Challenge, from ISIS and from the Health Quality Innovation Collaborative. And then finally, Dr. Michael Golby is going to facilitate a discussion around what we've learned, how can we share this, and then any further analysis. And so we all like to, when there's lots of participation in that discussion forum, and that's when we encourage you to use the question and answer feature on the webinar. Don't wait. If you have questions as you think of them, please type them in, and we'll queue them all up and deal with them then. So at Canada Health Infoway, we've been running these Imagination Challenges for 4 years, and with our partners, we help accelerate the development and adoption and effective use of digital health solutions across Canada. Basically, our vision is healthier Canadians through innovative digital health solutions. And while the Imagination Challenges, they seek to inspire, provoke, and promote innovation in health and healthcare and foster a community of innovators in Canada. Certainly, we've seen in all the 3 previous webinars a lot of interaction, a lot of discussion about this innovative way of finding questions or finding answers to questions that people have in the healthcare system that could influence policy as we go forward. Many of you may know that because of the success of this challenge, we've also offered the Data Impact Challenge 2. Voting on questions just ended yesterday, and we'll be putting those questions up for teams to answer starting December 15th. So do take note of those questions, and for any of you that have already participated, we urge you to do so again. And if you haven't participated, well, now's a good time to think about it. We couldn't do any of these challenges without our supporting organizations. You can see them all listed here. Specifically for this Data Challenge 1 challenge, we had considerable support from Choosing Wisely Canada, the Canadian Institute for Health Information, and CASPER as well. So all of those organizations helped frame questions. They provided us some judges, as well do all our supporting organizations help spread the word. The purpose of the Data Impact Challenge was to source relevant information for a set of questions that people consider are important for policymakers to know about. And so we wanted to test that feasibility, and are there new mechanisms or are there different mechanisms for getting answers to those questions? And we think this Data Challenge actually did so, and that's partly why we've gone into the second one so quickly. And so with all of our challenges, we are trying to spark innovation. We think we found a good thing here, and we hope you do too. And then by having these discussions, it actually helps us, everyone, understand the data, understand the implications of what we found, and how we might proceed further. So without further ado, I'm going to turn it over to Simon Higgins, Director of Benefits Realization here at Canada Health Infoway, and he's going to review some of the results at a glance.
Great. Thank you very much, Fraser. So as Fraser alluded, we put together this challenge. We put out a series of questions. In this case, we had 6 questions, and one of them was a multi-part question, which was all these Choosing Wisely Canada recommendations that we were looking at. We gave teams 64 days to weigh in with their answers to these questions, and we were thrilled to receive 41 submissions, which exceeded our expectations, and importantly, some very high-quality submissions in there and some really excellent work done by folks from across the country. So we had a number of different provinces and territories, lots of different kinds of organizations participating, lots of different data sources involved. So it really exceeded our expectations in terms of being able to go out there and source information from lots of different places that weren't necessarily on the radar. And then the last piece of that result at a glance, very importantly, is our judges. 35 judges participated in Data Challenge 1, some really excellent judges there, and we were able to have each submission judged by at least 5 of these judges, which gives us a really good breadth of input to determine which are the most important and most relevant submissions we'd received. And I should mention that all of those submissions, all of that judging information is available on the Imagination website. So now diving into the topic for the day, we're looking at the responses that related to a few Choosing Wisely Canada questions, specifically around a couple of their recommendations around family medicine. Their family medicine recommendation number 5 is don't do annual screening blood tests unless directly indicated by the risk portfolio of the patient. And their recommendation for family medicine number 8 is don't do annual physical exams on asymptomatic adults with no significant risk factors. So important recommendations that really speak to some of the utilization challenges that we see in primary care. And so we put these out and got a series of submissions. We've got a high-level summary of what these we found across those submissions, 5 submissions in each of those questions. And to share some of those, I'd like to invite Kira Pendrith to step in and share those. Kira is a biostatistician at Women's College and a research associate with Choosing Wisely Canada. Kira?
Thanks, Simon. So I'll just start off by saying that primary care is a real priority for Choosing Wisely Canada, and in particular, the annual physical exam and the testing that goes around the annual physical exam are 2 of our family medicine group's top priorities. So we're very excited about all of the work that everyone's done, and we're very eager to learn about these results. And so now I'll give you a little overview of the submission results. So for fasting blood glucose testing, across the province of Ontario, rates were about 40%, which is really similar to what was seen across the province of Alberta. Now we see some large differences in the results for low-density lipoprotein, though, which, sorry, could we go back? Just to touch on how in Ontario across the province, overall 33% of adults received at least 1 LDL. And then you'll notice that for Ontario partial, and this is from the Health Quality Innovation Collaborative, and I won't go into too much detail here because you'll be hearing from them afterwards on their methods, but you'll notice that there's a quite different rate of about 10% lower for LDL, and then in Alberta, across the province, the overall rate of LDL is about 10% higher than in Ontario. And then finally, this last blue bar here, again, this is only a group of practices, I think about 60 doctors in Ontario, so it's just a smaller subset of the province, and this team looked at their outcome was any one of total cholesterol, hemoglobin, or fasting blood glucose. And again, about 40% were seen. And so now moving on to the annual physical exams. In Ontario, for the overall province, and then for one of the teams, that was just a practice analysis. The first two are quite similar at about 20%, but then you'll notice that the third submission was only 5%. So we're hoping to discuss these differences a little bit more in the discussion. As well, Newfoundland, across the province, their rates of general assessment or an annual physical exam are quite low at only 3%. And then Alberta quite high, up at 35%. Okay, so hopefully in the discussion we'll get to some possible reasons behind these discrepancies in results.
Great, thanks very much, Kira, and yeah, very interesting to hear that summary, and totally agree that we want to get to some of that discussion around why are we seeing some consistency in some areas and some variation in others. So to set the stage for the discussion, we've got our two teams, and I'm going to invite our first team on the line now. That team is Team Fiscally Responsible, and we've got Laura McKagan, who is a quality specialist at ISIS, to present their findings. So Laura, can I invite you on the line?
Great. Yes, thanks very much for having me. So I'm just going to briefly go over some of the work that we did as part of the Data Impact Challenge, and it was really a team effort. So on our team we had Anna Chu, who's an epidemiologist, myself, Reza Rezai, who's an analyst, Annette Robertson, who's a project manager, and Jack Chu, who is the cardiovascular program leader and senior scientist. So the focus of our data challenge was for what portion of adults were screening blood tests done in a given year. And the way we interpreted the question was to really focus in on two specific types of screening tests, glucose and lipid screening in the Ontario adult population. And we chose 2010 to 2014. 2014 was the most recent complete year of data we had at the time. And it actually represents data from over 11 million Ontario adults in 2014. So the two main data sources that we use for this analysis are data sources that we commonly use at ISIS. They were the Registered Persons Database and the Ontario Health Insurance Plan, or OHIP, Claims Database. Now, the Registered Persons Database is a basic database we use that provides a lot of demographic information about Ontario residents. So, for instance, it provides their date of birth, sex, eligibility periods for OHIP coverage, and other information that we can use when deriving a denominator population. The OHIP Claims Database captures Ontario physician claims and claims from other providers, as well as lab claims for outpatient and community labs. And this was the database we used to identify who received a screening blood test in a given year. Both of the databases are provided to ISIS by the Ontario Ministry of Health and Long-Term Care. So for our analysis, we calculated the proportion of individuals who were screened for cholesterol and glucose by age groups, and we chose 18 to 39, 40 to 64, and 65 and above, as well as by sex and by year, so again, 2010 to 2014. Our numerator population was anyone who had at least one screening blood test during the study year, and the denominator was composed of all individuals who were eligible for screening at the start of the study year. And exclusions from this denominator population included people who were non-Ontario residents at the start of the year, they weren't eligible for OHIP coverage, or if they were less than 18 years of age. And here you can see some of our results. So our blood glucose screening results are shown in blue, and the lipid screening results are shown in sort of the red or pink on my screen. As you can see, overall, the blood glucose screening results are higher than lipid screening for every age group, and we see increasing proportions of individuals being screened by these tests in 2014 as age increases. So the 65 and older age group had the highest rates of screening at 66% for blood glucose and 56% for lipid screening. Overall, the blood glucose screening was about 40% in 2014 in the adult population 18 and older, and about 33% for lipid screening. Here we've plotted trends in screening among groups that are recommended by Canadian guidelines. So in the Canadian Dyslipidemia Guidelines and Canadian Diabetes Guidelines, there are recommendations regarding the appropriate groups for screening. So for blood glucose screening, it's males and females age 40 and older. And for lipid screening, it's males age 40 and older and females age 50 and older. And what we wanted to do was see if there were any trends in these groups for whom screening is actually recommended. So in our results, the top line actually shows screening rates in females age 40 and older for blood glucose. The second line shows females age 50 and older for lipid screening. The third indicates males age 40 and older for blood glucose. And then the final line is males 40 and older for lipid screening. As we can see again, the rates of blood glucose screening are higher than for lipid screening, and the rates among females are generally higher than those for males. We didn't see much of a trend across the years from 2010 to 2014. It seemed to show a relatively stable proportion of individuals being screened. Overall, the highest proportion screened in 1 year for these recommended groups was about 55%, and the lowest proportion was approximately 42%. And those were our results. I'm pleased to answer any questions that you might have. Thanks.
Great. Thank you so much, Laura. So this is the portion of the webinar where we'll invite questions for Laura about the analysis done by her team. So please, in the WebEx tool, you'll see the Q&A box. You can see on this slide it describes how to answer those questions. So please do go ahead and submit your questions or comments now. We've got one or two here for you, Laura. The first one is about the Choosing Wisely Canada recommendation speaks to the risk portfolio of patients. So we obviously didn't put that as part of the challenge question, but I'm wondering if you have any thoughts about the way you might be able to augment your analysis to try and identify those patients with a risk portfolio which would make them a more necessary candidate for screening.
Right. So we're actually working on some of that analysis as part of our study team. We're working on a study called the CanHeart study, which is looking at the quality of primary cardiovascular care in Ontario. And what we've done is we've actually used linkages with EMR data and other data sources to try to identify who's at high risk. So for instance, with EMR data, we can actually look at individuals' treatment for things like hypertension, their blood pressure levels, their previous risk factors as well, to try to really hone in on who's at higher risk and who's at lower risk.
Excellent. Very, very interesting. So another question, just generally, were you surprised at the rates that you were seeing when you were looking at the data? Was your sense or the sense of your team that these rates were higher or lower than you would have expected?
Personally, I think the rates were probably about what I would have expected. You know, we do sort of have the idea that there probably is a lot of over-screening that's going on and screening that, you know, isn't exactly according to guidelines. So we sort of had that hypothesis in the background, and I think our results sort of support that. However, something I think we would want to do to definitely confirm that that hypothesis is to look at screening rates over the 3-year period for which screening is recommended. This analysis only looked at the 1-year period, so we don't know of those individuals who are actually getting repeat tests. But overall, I'd say, you know, the results weren't totally surprising, but do possibly point to some over-screening.
Great, thanks. And so one more question we have here for you is, you noted that that there didn't seem to be a substantial change in the trend over time. It looks a little bit like there's a slight dip, but it sounds like it's not a significant dip. Would you have expected that changes in guidance over that time might have meant that there was some kind of a trend to observe?
I think we probably would have expected changes in trends if we had looked further back in the data. So guidelines, for instance, I believe there in 2008 there was a change in the dyslipidemia guidelines. I'm not sure if it was related to screening, but I suspect if we look further back, we might see some sort of trend associated with new guidelines being released and recommendations changing. But over this period, to my knowledge, there weren't huge changes in recommendations. So I think it's fairly plausible that we would observe a sort of stable trend.
Great. Thanks very much, Anna. I guess with the Choosing Wisely Canada campaign moving forward, hopefully this will give us a sense of some baseline, and we'll see if that trend does budge going forward. So thank you very much, Laura. Really appreciate your time, and would invite you to stay on the line and be part of the discussion in the latter half of the webinar.
Okay, great. Thank you.
So next we're going to turn to our second presenting team on the line. This team is from the Health Quality Innovation Collaborative, which is a family health team here in Ontario as well. And I would like to introduce Bogdan Pinzaro, who is a health informatics analyst. Bogdan, welcome to the line.
Hello, can you hear me?
We can hear you. Thanks a lot.
Okay, thank you. Yes, we're a small non-for-profit that are affiliated with a family health team, as in the physician that started this non-for-profit organization is a part of a family health team. So as part of my team, we had the founder of the organization, myself, and one of the programmers that's on our team in charge of databases to help us extract this data and to be able to do the queries from the back-end side of it. So in terms of our analysis, what we've done was we looked at both at the screening of blood tests and the annual physicals, and because our database was considerably large in the sense of 100,000 over 100,000 sample patients, and we had access to multiple family health teams, we decided to choose LDL, thyroid stimulating hormone, and hemoglobin as the three blood tests for which we decided to do analysis, mostly because we knew that two of them were guaranteed to give us results. The third one, we were curious as to see how many screenings have been done for HB and how it's been documented. In terms of annual, we looked at the billing code associated with an annual physical, and we had to look at two of them because it has changed throughout the periods that we were looking at. So we're looking at essentially 2013, 2014, and we looked at half of the 2015. And in terms of our methodology, the data is stored on our custodian organization server from these family health teams. We have approximately 18 to 20 family health teams in small clinics. However, due to connection issues or problems throughout time, we had to select a few of them. And the queries that were developed to extract this data were, in terms of the screening results, we had to pull up the whole list of available measurements as to how they were inputted in the database. And then we had to clean it up and understand which ones were specifically related to the three they were looking at due to data entry difficulties. The billing codes one was more assuring because of the fact that it's the physicians kind of have to bill to get paid, so that didn't have as much data input inaccuracy. And then the way we've broken down the data is we've taken all of these family health teams and we've looked at their trend and how that's changed over time, the pattern that we've noticed is that the number of screening had increased over time for most of these. As you can see, the LDL, because that was the one that provided the most relatively assuring, like more integral data set, there seems to be somewhat of a trend in increasing. Now we're not sure if that is due to how they input their data and how that's changed, or from the sense of them over screening their patients, and that is something that would be a good idea to look at in the future when dealing with this type of data. And in terms of the patient screening, and in terms of the physical exam, again, sort of the same pattern. There seems to be a little bit more decrease for some family health teams, increase for some of them. Overall, there's a slight increase, but that's because we had to, for 2015, we had to estimate. We had to estimate the percentage. So we calculated for half of the year, then we doubled the percentage to be able to get kind of a prediction. But at the end of the year, it would be ideal to do these queries again and see how the results have changed. And we're still waiting on all the data to come in. And that's kind of it from our perspective. If you have any questions.
Great. Thank you so much, Bogdan. Really appreciate that. And again, this is the point when our attendees, our participants, can write in with your questions for Bogdan. So we do have a couple here. So really nice to see that we've got a team from ISIS who's looking at a provincial data set, and then also, Bogdan, to have you and your team dealing with a practice level data set. The first question relates to the capacity at the practice level to do this analysis. So can you tell us a little bit about how you were able to build up this capacity and the kind of analysis that you do for HQIC?
Okay, so for HQIC, I am a Health Informatics analyst, but for the family health teams individually, I'm a quality decision support specialist. So for most of these family health teams, they use OSCAR as their choice of EMR, and OSCAR allows for multiple ways to input data, and most of the time I've been working with trying to have those protocols in place and being able to extract the data from the EMR. So that's been the constant battle with ensuring that the accuracy of all the results that have come in. The more, the trends that have been a little bit more even, and you can see like a slight increase, those are the ones that have, those are the family health teams that have successfully, not 100%, but 80 to 90% gotten a chance to input their data appropriately to be able to get the analyses. And yeah, that's kind of it.
Great, thanks. That's very helpful. And then a follow-up question to that. So clearly, you know, across some of these the clinics, there's some variation in terms of the rates of both screening and annual physicals. When you share this data back with some of those clinics, how receptive are teams to having this kind of data feedback?
They're very positive about it. They are interested in it, but they would like to do more on their individual level. So they would like more of a personalized. This is more of an overall looking at a bunch of them, so it's a very high-level analysis. But it would be for them. They would prefer more into their own practice to understand why these guidelines or these trends are this way for their specific practice. So
Great.
This is a good eye opener, but they would prefer more of a one-on-one approach.
Okay, excellent, thanks. We've got a question that dives into some of your comments about data accuracy. So we've got two different questions that you tackled, slightly different ways that data is coded. Can you talk a bit about some of the limitations within the EMR in terms of the way it's captured and what the implications were for you in terms of your ability to answer this question accurately?
One of the limitations was how the measurement itself was put into the EMR, because we extract raw data back from from all of these EMRs, so we only see the names as LDL or lipoprotein or LDL with an accidental marker beside it. So this is how the data entry, we get a list of all the possibilities that specific data set could be entered, and we have to go and clean and look through all the elements. So it's a constant back and forth to make sure that how it's been inputted versus how it's been come out. The only one that has been consistent mostly have been the billing codes, because those kind of have to be put in by physicians. So those offer a little bit more accuracy than, and there's no ability, there's no free-form text fields for them to input that billing code. So.
Interesting. So when it comes to those screening tests, you're capturing the data directly from the order that the physician has entered, rather than from the test as it's returned back to the EMR?
Both. So we get it from both, and it gets collated together, and then we look at the ones that are specifically as a measurement. Those will appear as LDL pure data points. The ones that have been put in manually by different family health teams, those are the ones that offer a little bit more difficulty in cleaning the data.
Okay, great. Thank you so much, Brian. Those are our questions for you. Really appreciate your time, and as I said to Laura, we really appreciate you sticking around on the line for the upcoming discussion. Now, just very briefly, we wanted to refresh your memory about this high-level summary of the findings. So we saw some trends, especially around glucose, around the annual screening, but then when we look at the annual physical, we see a lot of variation there, which I think is an interesting topic for us to discuss. But with that, we've ended the time when we're giving you a big data dump, and we're moving into the discussion. So I'll turn it back over to Fraser Ratchford.
Thank you, Simon. And so this afternoon's discussion is going to be facilitated by Dr. Michael Goldby. He's a semi-retired family physician who lives in Kelowna, BC, where he had a full-time service practice since 1983, having attained his MD from UBC in 1980. He has worked in the UK, Uganda, and various parts of Canada. He has had a long involvement with medical organizations in Canada, including president of the BC Medical Association and chair of the Canadian Medical Association Board of Directors. He was a member of the Canada Health Infoway Board of Directors for 6 years, and he has a long-standing interest in electronic medical records and is convinced of the value that they will add to providing care to patients. He is currently the chair of our Infoway's Clinical Council. And before I ask Michael to step in, I also want to remind everyone on the call that Kira Pendris will also be part of this discussion. And I also want to introduce Dr. Rashad Bayat, one of Canada Health Infoway's clinical leader and a family physician. And as Simon said, both the teams team fiscally responsible from ISIS and team HQIC are going to join while Dr. Goldby takes us through the discussion. Over to you, Michael.
Good. Thank you very much. Good morning or good afternoon, everybody, depending on where you are in the country. That was, I really enjoyed those presentations, terrific discussions, and I think there'll be a lot more discussion. Having been involved in family practice for the last 30-something years, we've gone from screening being really useful to screening being a waste of time to being useful to being harmless to being harmful. So it's terrific to be able to actually focus this, and it's also terrific to have Choosing Wisely Canada really leading this discussion as to where we should go. So it's good stuff, it's timely, and what you should have in front of you is the first poll number 1, what have we learned? And I would like to ask you this question. You'll have a minute to answer it. Do these submissions increase your understanding of the rate of screening blood tests for adults? So you have 3 choices, yes, no, or I don't know. So if you would like to vote on that right now, and then it'll just take us a minute to bring the answers up, and that'll help us understand as to how valuable this whole exercise is. So,
Michael, I think it's Simon Infoway. I think we've got a glitch in the poll that's showing for folks to actually submit to. So we will try and get that sorted out.
Yes, we opened the wrong poll. It was polling number 4.
Okay.
If you can redo, we can open the first poll if you can give me just a moment, and we can redo that one. We can redo that one. It's not a big deal.
Okay, that would be good. So maybe while we're waiting for that poll to come up, I have a couple of questions that either other people who are on the call or the teams could think about answering. So they're both actually about how the data was gathered. And this may be because it's from Ontario and doesn't apply in BC, but I would like to know how you knew that the lab tests were actually screening tests and not lab tests that were required for the treatment of disease. And the same thing with annual physicals. How do you know that they are annual physicals in healthy people and not physicals that are done for other reasons? So that's something maybe to think about, and we can discuss once we get this poll. So we have the first question up again. I'll ask it again. Do these submissions increase your understanding of the rate of screening blood tests for adults? And you have the choice of yes or no or I don't know. So I wish I could play some Jeopardy music, but I can't. So please go ahead and answer your question. You click on the button and then click Submit.
You could hum some Jeopardy music for us, Michael.
You really, really, really wouldn't want me to do that. So the question is there. Hopefully everybody can see it, and I'll just give you another 10 seconds to answer it. Then it takes a few seconds for the results to be tabulated. So I think everybody's had long enough to answer the question, and we'll close that poll right now.
And just one moment for the results.
Okay, thank you. I guess I'm not a very experienced broadcaster because dead air would never happen on CBC.
In just one moment.
Okay, that's great.
Okay, and you should be seeing the results now.
We do. So I think everybody can see the results there. So of the people who answered, 65% said yes, it does increase our understanding, and 18% said no, and 18% said I don't know. So the vast majority of the people on the call felt that this was useful and did help increase our understanding with the rate of screening. So if we can move along to the next slide now, please. And it's basically the same question for understanding with the rate of annual physical exams for adults. So again, if we could have that poll up, please. So do these submissions increase your understanding of the rate of annual physical exams for adults? Again, you have 3 choices, yes, no, or I don't know. So that poll is open, and please vote now. Okay, we'll give everybody a couple of seconds to answer that one. Don't forget to push Submit when you're happy with your vote. So if you can do that, and then we will close that poll now. Thank you. And a couple of seconds without me singing or humming or... Actually, I'm doing a dance, but fortunately, this is not video, so you can't see me doing that.
We can picture the dance.
Again, I don't think you really want to do that, but by all means. Okay, the results should be available pretty quickly. Okay, we have the results for that one. Thank you. So again, 58% felt that it did increase our understanding. 32% said that it didn't, and 11% said they weren't sure. So similar results to the previous one, perhaps a little bit less useful than the previous question. So if we can move on to the next slide now. maybe this slide is, yes, we can do this one as well. What have we learned? So, Simon, do we want to do this slide now, or do we have any more questions or discussion at this stage?
So this one isn't, in fact, a poll. This is just a general discussion slide. So we can with whatever discussion questions you're interested in throwing at our panelists.
Yeah, and Michael, I think your one that you posed as the polling was coming up is a good one, and I'd love to hear everyone's sort of response to, you know, how could they tell what kind of physical it was, and also around the tests as well.
Okay. Yeah, I'd be interested to hear that. So either team.
So Laura, do you have a response for Michael?
Sure. About the generalizability or the testing. So I think for generalizability, for our results, we can be pretty confident that they are generalizable to the Ontario population because we do have data that captures the whole province. But there are limitations such as what Michael had discussed, that we don't necessarily know the reason behind ordering these laboratory tests. So what we can do as part of our analyses is try to exclude certain patients who are more likely to receive the tests related to a disease rather than for screening purposes. But that is sort of an inherent limitation of our analysis as we don't have the reason behind the blood test being ordered.
Okay, and similar, then the other question was also about annual physicals. How do you know that they were screening physicals, basically, in otherwise healthy people?
I don't know if Bogdan, can he respond to that? We didn't analyze that as part of the submission.
Right.
Bogdan, are you still there? Actually, I'm going to ask, yep.
This is Kira from Choosing Wisely. Laura, I have a question for you. Do you have any sense of if your rates are underestimating the true screening rate because of labs that are done in hospital, and how much this might be?
Yeah, so you bring up a really good point as well. So we don't have information about labs that were done in a hospital. Therefore, it is likely to be an underestimate. By how much, we don't really know. There is new data that is in the process of coming to ICIS called the Ontario Laboratory Information System data, so the OLIS data. That data will actually include hospital labs. So once we get that information, we'll be able to have a better picture of what the true rate of screening is, including the hospital-based lab. So right now we don't really know how much of an underestimate it is.
That'd be really interesting to compare just with OHIP and then also with the lab data system.
Yeah. I mean, we do, as an alternative, we do have some electronic medical record data as well, where we can look at this kind of information. But again, that data isn't as generalizable to the whole Ontario population because it's not, not evenly distributed across the province. So definitely, when we get the OLIS data, it'll be interesting to look at those lab tests as well.
Thank you.
While we're waiting for Bogdan to respond to the physicals, just reminding everyone, please use the question and answer feature to continue questions coming in our way.
Hello?
Yep, go ahead, Bogdan.
Oh, yeah, sorry, I got cut off, and then when I tried to dial back in, I was put in as a participant. So in terms of the screening of physical, that is a very difficult one to measure considering we're only using billing codes. However, from the appointment booking perspective, there is a way to book a physical and mention what it is specifically, and there could be a cross-reference between the billing codes and those appointments to figure out how many of those were actually for screening purposes in a specific age group, but that would require further analysis and development of queries. But that's one way that I could see that happening at a yes.
Yeah, thanks. Can I ask, ignorant about this, is annual annual physicals a covered benefit in Ontario? Is it paid for?
Yes. Well, the physical in general doesn't refer to, it's not categorized as specific.
Okay, because certainly in BC, even though physicals are done, they're specifically not supposed to be. They're not covered. So there may be a difference. Earlier on, one of the slides showed a large discrepancy between annual physicals. I think it was in Newfoundland and in Ontario, and that may be part of the reason is as to actually what is, in theory, paid for by the benefit plans.
Okay, and that's something that needs to be looked at carefully, because those were the codes that I was provided by the physician, so I can't comment too much. And those are the ones that were mentioned as being specifically related to physical exams in general.
Well, we actually have an Ontario physician here who, Rashad, do you have some thoughts on this?
Sure, thanks, Fraser. I can just maybe provide a tiny bit of insight into the billing side from the Ontario perspective. I know in Bogdan, in your data, the HQIC data, two of the physical billing codes that you used were the A003 and the K131. So the K131 code, to answer Dr. Golby's question, so physicals are remunerated, in physicals in quotation, they're called periodic health exams or whatever you want to call them now, but they're broken down by age, so there's a different type of remuneration depending on the age of the patient. So from my recollection, the K131 billing code is for patients aged 50 to 65. And so in Bogdan's data, you'd be capturing folks over 18, but the K131 narrows it down to people over 50. But to parse that data out a little bit more to see if, to answer Dr. Golby's questions, were those being done on individuals who were healthy or who had pre-existing medical conditions, that would be a little more challenging. You'd probably have to dig into previous billing codes that those patients had to match up, sorry, not billing, but diagnostic codes, had physicians attach diagnostic codes to their billing codes. You could probably narrow that down a little bit more. But my speculation is that the K131, the age which narrows it down to 50 to 65, you're more likely to have at least one medical condition in quotations. I'm not sure if that muddies the waters or if that elucidates it a little bit.
Well, I think it partially answers the question of one of the key limitations, and at this stage we're just not sure how that we actually are answering the question that's being asked because it's difficult to really define what is screening. That would be my takeaway from that.
Yeah, and another interesting discussion point which I'd throw out to the group is, is it possible to know if these kinds of physical or periodic health examination visits are clinic-initiated or patient-initiated? There's a lot of expectation still in certain patient groups of having an annual physical, and there's a lot of education that needs to go into around the idea that the concept of the physical has really become outdated and has lost, there's very little evidence to support it these days. So it's sort of just a general discussion point.
Has the sorry to interrupt, has the K131 code been changed recently, or is it?
Do you mean?
Updated? In terms of what it covers?
In terms of, you mean the amount that it's remunerated, or the age?
The age. Yeah.
No, I don't think so. But again, don't quote me on that. It could have been updated more recently than I'm aware. I would say up until even last year, it was still age-related.
Okay, because on April 1st, 2015, I have the code as being for ages 18 to 64. That's probably why it was.
18. Okay, that's possible. Yeah.
So a question has come in from somebody who's on the call. Other than costs, what are the problems associated with overuse of screening blood tests and yearly physical exams? So who would like to tackle that question? Nobody wants to tackle it.
Well, this is Kira again from Choosing Wisely, and I'm not a clinician, so please take what I say with a grain of salt. But with any diagnostic test, and I guess this doesn't apply to physical exams, but there are some risks of finding things which are abnormal, but not that won't necessarily lead to something. So if you have an abnormal test, then that can lead to further downstream testing or repeat testing, and that can cause the patient anxiety. So that's a problem with over-testing. I don't know if any of the clinicians want to weigh in on this and perhaps correct me. But.
No, I think that's a very good answer, and the prime example of that is the controversy around PSA testing. I mean, it's a huge controversy. It's as much political as it is clinical, and exactly what you said. There are many people who believe that it can be positively harmful to do the testing. So, thank you. Anybody else want to jump in on this one?
Yeah. So, Dr. Goldie, it's Rashad again. You know, it's not so much a cost thing, although that does factor into it. It's exactly, was it Kara who you commented? Yeah. So it's exactly that you can dig up things. You can go on fishing expeditions that dig up issues that may be completely incidental findings that may be within the normal variation for you as an individual that may not actually relate to disease but may introduce further investigations and queries and more investigations that could potentially be harmful to you as an individual. So, I mean, there's the PSA one is a good one, a good example. There are others like that kind of fall into those categories where tests may be borderline and could appear abnormal because of a lab variation or a lab error, and then may result in more unnecessary testing and anxiety for patients, which is really potentially counterproductive to their health.
And just to add to that, then also the patient has a lot of other things that they have to do. They have to take time off work and all of the associated things with follow-up testing.
Yeah, thank you. Thank you very much. Are there any other, I don't see any other questions on my screen. Are there any other questions or comments at this time?
This is Kira again. I just have one for the two clinicians, and this is related to the annual physical exam and how there's such variation that we saw from 3% in Newfoundland to 35% in Alberta. Do you think that these numbers are too low on one end and too high? Do you think that there is maybe a range that is an appropriate level of annual physicals?
Or maybe, Kira, another potential answer is that there's a coding issue or a data quality issue that is generating those numbers.
Yeah, that's an excellent.
Yeah, so I'd love to hear the feedback on that.
Okay, so I guess I'll jump in again. It's Rashad here. So I've worked in Newfoundland before. I did my residency training there. Most of the physicians in Newfoundland at the moment are still fee-for-service, as far as I know. Please, someone jump in if that has changed significantly. I'm pretty sure it's still, vast majority are fee-for-service. So it could reflect, a billing-related issue. It could reflect a practice model issue. There's a number of possibilities there. And again, it could reflect, Newfoundland has a fairly low penetration level of electronic medical records, which if you're looking at annual physicals as a point of contact with the patient to initiate conversations around screening, it's very challenging to contact certain populations within your patient group, your patient population, without an electronic medical record. So those factors could all play a role there. But I would put that out for discussion to the group.
Thank you. So from either of the presenters. Any comments on that?
Yeah, I think I agree. This is Laura. I think I agree with the previous comments about it's probably, related to different billing procedures and different coding procedures across the country, at least in part. And, I mean, also it might reflect access to healthcare services and the culture around physical examinations as well. Like from our work in Ontario, we've shown that there are variations in rates of what we think are annual physicals across the province. So it could also be related to other things like, socioeconomic status, comorbidities as well. So I think there's a lot of factors that can come into play here.
Thank you. Michael, as we come to a close on the webinar, do you have a comment on that and your sort of 30-year experience on what might explain the variation between all the jurisdictions?
I think, listening to the conversation, I think a lot of it is just the way that the coding is done and how physicians actually code and bill. But also, I believe there are variations across the country as to what is, in quotes, allowed and what is not allowed. There's, even within provinces, I think in BC, you would see differences between the expectations from our patients as to whether they should have an annual physical or not. It depends on sometimes their ethnic origin, where they come from, what they expect. So there are so many variations. So that, to me, the answer to this first question, is this data generalizable? I don't think it is yet. But what this does for me is it asks a lot of questions, and I think we as clinicians and the payer should be very interested in moving this along to getting much better information. And again, I go back to Choosing Wisely Canada. I think that group is fantastic. They're going to be the focus for moving us ahead on this.
Great. Well, thank you very much, Michael. We have two quick polls to do at the end here as we have 3 minutes left. The first one is, how can we share the evidence? We'd like you to answer this multiple choice question, pick all of them, none of them, but if you could answer that question quickly as we wrap up. I'll start my thank you to everyone as this poll continues, and we'll close it in about 15 seconds if we could. Thank you to everyone who participated in the call today. Our teams from ISIS and HQIC, good presentations, and I think Michael hit the nail on the head that answering some of these questions actually raise more questions, and it means we want to delve into the data even more. And so I think as we it makes us ponder all of the results and make us think about how we do want to practice or what other questions we have as they go further. So we're just waiting for those results to pop up. And there we go. And so we can see how people would like to access it. And then let's just move quickly to the final poll, which is how would you like to participate in any future challenges? And as you know, we have our current challenge, so I'm hoping most of you are going to pick as part of a team. And so as of December 15th, on the second round of the Data Impact Challenge, the questions will be available. I urge you all to go online, look at those questions, form a team, and answer them. And so let's close this poll as well and see how people would like to participate with this in the future. Thank you to Michael. You did an excellent job moderating. Kira, Rashawn, and our teams, that was great. Thank you to Team Infoway here for making this possible. So let's hurry up and see if we can see that last result before the 2 o'clock time comes up. There we go. So we do have some people that will participate as a team, but most importantly, we have users of the data, and I think that's excellent because this information is valuable for the health system. Thank you to everyone for today, and I wish you a good rest of the day. Thanks for joining us.